And in 1976, Canon Al spoke of hyperandrogenism, which we're going to look at, insulin resistance, and acanthosis nigricans. As we go along, you all will understand these terms, okay? So it's just to give you a background as to how far back PCOS went. Stein and Leventhal were the ones who were the first profound investigators of polycystic ovary syndrome in 1935. All right. Now you may ask, why is it considered a syndrome? Why do we use the term syndrome? Because there are other illnesses where we don't use the term syndrome. A syndrome is any illness which is characterized by a set of symptoms or signs that is unique to that particular illness. Okay, so we have a few signs and symptoms which you're going to look at, especially when you look at the criteria for diagnosis of PCOS, that is characteristic of PCOS. In other words, they must be present for us to say that the syndrome is PCOS. We're going to start off now with the criteria for diagnosis. How do we go about diagnosing someone with PCOS, right? This may take different forms and presentations, as you will see later on, and it's usually a question that people ask, what type of PCOS do I have? But first, we have to look at the criteria for diagnosis. We have three main criteria for diagnosis. One, where you see chronic anovulation, is what it presents itself as an irregular menstrual cycle, right? The other one is hyperandrogenemia, or in smaller terms, high male hormones. And then we have sonographic image of cystic ovaries. So in these three criteria are what we look for to diagnose someone with PCOS. Now, in endocrinology, an adolescent, a teenager, must present all three. And it has to be 2 years from menarche. Menarche is your first menstrual bleed. So it has to be 2 years away from menarche. And the teenager must present all three for us to say, let's say a 16-year-old or 15-year-old has PCOS. In the adult woman, we only look for 2 out of 3. So for example, somebody comes in, they have high male hormones and an ultrasound which shows characteristics of polycystic ovaries, I can diagnose that individual with PCOS. Somebody comes in, they have an irregular menstrual cycle and a sonography which shows polycystic ovaries, I can go ahead and diagnose. Or someone comes in, which is the one that usually shocks the clients, with high male hormones and a irregular menstrual cycle, but absolutely no cysts on their ovaries. I can still diagnose that client with polycystic ovary syndrome. So that's to say, which is one of the things that I wanted to dispel. A woman does not have to have cystic ovaries for her to present polycystic ovary syndrome. Everybody got that clear? As you go along, if you have any questions, you can write them down, because sometimes even on diagnosis, there's a lot of confusion. We're going to have a look now at the hormonal disorders. In order for you to understand the hormonal disorders, I'm going to explain to you the main hormones that form part of PCOS and their roles. So we can, if we understand what happens normally, then it will be easier for us to understand the abnormal. So we're beginning with estrogen. Estrogen produced by the ovaries, it helps stimulate the growth of the egg follicle. Okay. Progesterone, when an egg is released by the ovary, progesterone encourages the thickening of the uterine lining, ready for a fertilized egg to implant into. So it helps with the thickening of the lining and proper implantation. Androgens, which are the male hormones, and yes, they have an important role in the woman's body. They kickstart puberty, they maintain the sex drive and mood. Insulin regulates the blood sugar levels. LH and FSH. LH stimulates the release of the egg, called ovulation. It controls testosterone and estradiol, which is estrogen production. And FSH stimulates the development of the ovarian follicles. So that means I'm sharing this with you all because when you go to your blood test, I need you to have an understanding of what we, the doctors, are looking for. Because the more informed you are, the more you understand the process of what is going on, is the more you will be inclined to take the necessary steps as to for management. Okay, so these are the hormones that play a very important role in PCOS. And when we send you for testing, we're looking at the levels of these hormones to decide, to understand what is going on with you. Okay? The first hormonal imbalance, as we usually say, that I want to look at is the one most times precipitates PCOS, meaning most people present this hormonal imbalance, and because as a result of the dysfunction, the hormonal dysfunction caused by this hormonal imbalance, then they develop polycystic ovary syndrome, and that is insulin resistance. Okay? We know that insulin is the hormone which controls our blood sugar levels. It helps the body take blood sugar from the bloodstream and take it to our tissues for energy. However, certain people present insulin resistance, and the word speaks for itself. Our tissues, they do not receive or process insulin how they should, and this leads to an accumulation of blood sugar in the bloodstream, right? So here I'm showing you a vicious cycle where you eat food. Now, even before we eat food, our pancreas begins to secrete insulin. From the fact that your mind knows that it's time to eat, your pancreas already begins to secrete insulin. From the time you take the scent of food, your pancreas secretes insulin. When you sit to eat, your pancreas secretes insulin. So you eat food, your body makes insulin, your pancreas here makes insulin. The cells resist that insulin. All of that glucose is stored. It's not being used, so it's stored as fat. That storage of fat, that high insulin level, that high glucose level makes you feel tired. You feel hungry, especially after you've just eaten. What does that say? Yes, you ate recently, but you're still tired. You're still hungry. So what do? You go back and you eat again. And the vicious cycle continues. So that's how insulin resistance works. This diagram is basically showing the normal process of insulin and glucose in the bloodstream, and this is how it looks when we have a buildup of insulin and glucose in the bloodstream. Okay, now there are certain things that we look for as doctors that I need you all to know and familiarize yourself with, so that if you meet somebody, let's say it's a family member or friend, you'll be able to identify the signs and symptoms so that you could advise this person to get tested. Now, why do we in endocrinology focus so much on insulin resistance? One, because it's very, very common. And two, it is the first step when you study the pathology of type 2 diabetes. In most cases, it is the first step that we can diagnose and treat to prevent someone from becoming diabetic. So just imagine if you have a population of 100 people and 50 of them have insulin resistance. If I can treat and reverse that insulin resistance, these are 50 people that I'm preventing from becoming diabetic. Okay, so that's why I'm stressing so much on insulin resistance. Some of the signs that we look for: one, you will see here the neck of a young woman, and you will see the hyperpigmentation. You will see the darkening of the skin, and this is known as acanthosis nigricans. Okay, and it is caused most times, not every time, but most times it is caused by an accumulation of insulin in the bloodstream. It can be found in the neck, beneath the arm, under the breast, and between the thighs. All right, so on physical examination, we look for the sign, very, very common. And also, clients who are insulin resistant, they tend to have what we refer as central adiposity, meaning the fat deposit is usually in the area of the abdomen. And we know how dangerous abdominal fat is and how hard it is to lose. So that's usually the area of deposit of fat in patients who suffer from insulin resistance and who suffer from PCOS. And this is detrimental because just as you see the fat on the outside, it also coats the internal organs, including the liver. And we are seeing now that clients who suffer from PCOS, they develop what we call a fatty liver, hepatic steatosis. And that fatty liver, if it's not dealt with, eventually can even lead to cirrhosis of the liver. Okay, so it's very important to pay attention to this. What are some of the signs and symptoms of insulin resistance? Abdominal obesity, which is what we spoke of, difficulty losing weight, cravings for sugar or carbohydrate-rich foods, and those cravings usually occur at night, a fatty liver, chronic fatigue or low energy, or just tired. You cannot think of what you did during the day to make you so tired. You just have low energy. Brain fog, high blood sugar levels, skin tags, dark patches on the skin, which is what we spoke about, high blood pressure, frequent urination, and being thirsty all the time. And you all will notice that these signs and symptoms sound a lot like diabetes. Okay? These are some of the complications of insulin resistance: high blood pressure, inflammation, the cravings, high cholesterol and fat levels. Sometimes, because of the peaks of insulin in the bloodstream, you could even have blood sugar drops, hypoglycemia, heart disease, stroke, cancer. And I'm only talking about insulin resistance on its own. So just imagine if you have insulin resistance, being a polycystic ovary syndrome client, or combined with hypertension, or combined with some other illness. It just exacerbates all of that. Gout, depression. Okay, so these are some of the complications of insulin resistance. One of the reasons why it is important to recognize it, to diagnose it, and to have it treated. So I need you all to take that back to your community. A lot of times the doctors focus on diagnosis of diabetes itself or pre-diabetes, and they do not screen for insulin resistance. Okay, to screen for insulin resistance, we do not use the same screening that we do for diabetes. To screen for insulin resistance, you have to do a fasting insulin. So if you suffer from PCOS, one of the blood tests that you must do is a fasting insulin test. Okay, because you could have insulin resistance, but it has not progressed yet into prediabetes or diabetes. And by treating that insulin resistance, then we can prevent you from becoming pre-diabetic or diabetic. Good. We're going to look at the next very common hormonal disorder, very troublesome, and that is hyperandrogenism. When we speak of, anytime you hear me say androgens, I'm talking about male hormones. Okay? And male hormones do play a very important role in the woman's body, in the woman's physiology. So anytime they are off, then we get certain signs and symptoms. The most common sign of hyperandrogenism in a sister, in someone who suffers from polycystic ovary syndrome, is hirsutism. What is hirsutism? It's excess hair growth, male pattern hair growth. No, not anyone who has excess hair growth has hirsutism, because hirsutism has certain characteristics. It must be terminal hair, meaning that thick, dark hair, and it has to be male pattern growth. So, for example, you may have hair on your forearm. It is normal for a woman to have hair on her forearm. So that hair on the forearm cannot be used as an example of hirsutism. Okay? You may have hair on your legs. It's normal for a woman to have hair on her legs. So that cannot be used as hirsutism. There's actually a chart that we follow to score how hirsute you are. Okay, so hirsutism is a common manifestation of hyperandrogenism. Usually we see it on the chin, on the upper lip, on the chest area, on the abdominal area, and on the back. So we give a score to each area where you have that excess terminal hair, and then it would tell us how hirsute you are, and then based on your score, we'll determine what treatment that we're going to use to treat that hirsutism. Other signs of hyperandrogenism of high male hormones, we have acne, the oily skin, and hair loss, androgenic alopecia. So all of these are expressions of hyperandrogenism, but the most common ones is the excess hair growth and acne. Okay. Here, for example, I have a client, two clients actually, who suffer from hirsutism. So you can see the different pattern of growth. And then I place this photo as an example of also two methods of getting rid of the hair. So the one to my left waxes. That's the one you can see where it's less on the chin. And then the other one uses the razor. So there you can see it's much more, and then she has signs of folliculitis. Okay. There is something that I'm going to share with you all next, which is also an expression of hyperandrogenism. However, it's on the extreme spectrum. Okay? And this is virilization. It's not very often spoken of, but it's quite common. What is virilization? It is when the female body develops physical characteristics that are similar to the male body. That means, due to the excess of androgens in the body, women that are affected by virilization may develop secondary sexual characteristics, which makes them more like a man than a woman. For example, the voice changes. So they would have that deep voice of a man, more muscle mass, male pattern baldness, acne, an enlarged clitoris, or what we refer to as clitoromegaly, mood changes, poor libido, or low sex drive, and irregular periods. So that's when the androgens in the body are so high and also have gone for such a long time untreated that that client is actually what we refer to as virilized. It's almost as if they were transforming into a man. And this is a photo from Stein and Leventhal, the lady that you're seeing on the side. It's not a man, it's a lady who allowed her hair to grow out and so forth. So you can see here, she looks like a man, but that's actually a woman. So that's an example of that's a painting done back in the days in 1935 of a virilized woman. So then we have to pay attention to that also. For example, I think I've had a few cases, maybe about 3 cases of clitoromegaly. So that's an enlarged clitoris, and it was because of extreme, very, very high levels of testosterone. One particular case was referred to me due to infertility. So they were suspecting that she had polycystic ovarian syndrome. And on physical examination, I observed that she had an enlarged clitoris, much larger than it is supposed to be. And then in studying her testosterone level, both her testosterone levels and her androgens from her adrenal gland, because the adrenal gland also produces androgens. Both of them were elevated. Very interesting case. Okay, so you could have a simple case of hyperandrogenism, but there are women who actually pass on to the phase of virilization. We're going to move on to the next hormone, which was one of the first hormones we spoke about when I gave you all the slide with all the hormones, and that is estrogen. Now, most times there is confusion when it comes to estrogen. Most people think that women who suffer from PCOS, that the most common disorder with estrogen is low estrogen, but actually it's the opposite. What we observe most times is that the women present something we refer to as estrogen dominance, hyperestrogenism, meaning higher than normal or higher than needed estrogen levels. Okay, higher levels of estrogen is known as estrogen dominance and can occur, is very frequent in women with PCOS. The constant exposure to that high level of estrogen, what can it cause? What are the symptoms that you may feel? Fatigue again, insomnia, brain fog, headaches, breast tenderness, and you may develop fibrocystic breasts, mood swings, particularly before your menstrual period, irregular, heavy or painful periods, abdominal fat, fluid retention, and bloating. Okay, so these are some of the signs of estrogen dominance, and that's one of the things that we look for also when we are examining you and we are screening you for PCOS. Here in this slide, you see an example of polycystic ovary syndrome where we have a normal ovary. If you look at the normal ovary, you will see that you have a primordial follicle which develops into a primary follicle, which develops into a secondary follicle, which develops into a mature follicle. Ovulation happens. This is the normal process that happens in a woman who does not suffer from PCOS. If you look to the other ovary, you're going to see multiple immature follicles. Development has stopped. And this is what happens in a woman with PCOS, in most women with PCOS. Now, I'm putting the slide here so you all could understand what I'm going to share with you next, which has to do with the criteria of polycystic ovaries. When your doctor says to you that you have cystic ovaries, The cyst is not actually, because most times when we think of a cyst, we think of something filled with fluid, right? That cyst is actually these immature follicles that you're seeing here. So this is what we see in the ultrasound. So the follicle that is supposed to grow into a mature follicle to become an egg so that it could be fertilized and you could get pregnant and all of that, that process does not happen. So you just stay with multiple immature follicles, and it is expressed in the ultrasound as, if you can see here, as cysts. So we have a normal ovary, right? And then we have a polycystic ovary where you see the cystic images. So that is what it looks like on sonography. But they are actually immature follicles. Sonography, no, not every cystic ovary meets the criteria of polycystic ovary syndrome. In other words, having cysts on your ovaries does not mean that you have PCOS. There is a difference between PCO, which is polycystic ovaries, and PCOS. Okay, I need to get that clear because a lot of times people do ultrasounds, and because they're told you have cysts on your ovaries, they automatically think that they have PCOS. There is actually a criteria that we look for when your cystic ovary is described by the sonographer to see whether it fits the category of PCOS. So you need to have either 12 or more follicles measuring 2 to 9 millimeters in diameter, and or an increased ovarian volume of more than 10. Okay? So that's the criteria that we look at sonography. So if somebody comes to me, their ovarian volume is below 10 and they have 3 cysts on each ovary, it does not meet the criteria for polycystic ovary syndrome. So I cannot say that I'm going to put that. Remember, I said at the beginning that we need 2 out of 3, at least 2 out of 3 of the criteria that we looked at. I cannot use that sonography as one of my criteria because it does not suit the description of polycystic ovary syndrome. It suits the description of a polycystic ovary, but not of polycystic ovary syndrome. Okay? That's why I placed this slide here, so you all could have that clear. All right, so these are some of the common disorders that we see in PCOS. There are many more. I just wanted to highlight for you all the most common ones. Okay, now PCOS is an illness we refer to as a diagnosis of exclusion, meaning before I can concretely diagnose someone with PCOS, I have to ensure that they do not present other illnesses that can mimic PCOS, meaning they have very similar characteristics to PCOS. One, top of the list, thyroid dysfunction, especially hypothyroidism, low thyroid function, adrenal tumors or an enlarged adrenal gland, hyperprolactinemia, which is high prolactin levels. Prolactin is another hormone that is produced by the pituitary gland, and Cushing syndrome, which is characterized by high cortisol levels. So when you are being evaluated or you're being screened for PCOS, that means that clinically, meaning on inspection and when your doctor is observing you and examining you, they need to ensure that these things are not present. So for example, you might go to the doctor suffering from PCOS and you might notice that one of the things we do is that we look for breast secretion because we're trying to see if you have any signs of high prolactin, because high prolactin can mimic PCOS. So it's not only that you're going to do the hormones that are directly related to PCOS, you also need to get your thyroid checked. You have to check your prolactin levels, etc., to ensure that you do not suffer from these illnesses. And then we're just not saying that you have PCOS by the time it's low thyroid function you have. And then you're going to be treated for PCOS, but you're still continuing the signs and symptoms because your thyroid function is low and it was not treated. And also they can coexist. So there are a lot of cases of especially hyperprolactinemia and hypothyroidism. We have a lot of cases of people who suffer from PCOS, but they also suffer from low thyroid function and they also suffer from high prolactin levels. Okay. The famous question that I always get from the clients, what type of PCOS do I have? Now, there are many ways to classify PCOS. The one we like to use in endocrinology is the ABCD categories because it's very easy for the patient to grasp, okay? To remember that they're type A instead of saying, I have classic. PCOS. So type A, remember we spoke about the 3 criteria. We have everything in type A. And in Dominica, I'm not too sure for St. Vincent, but in Dominica, this is the most common type of PCOS, okay? Delayed ovulation, so that's the woman who presents an irregular menstrual cycle. High androgens, high male hormones, and sonographic polycystic ovaries. Okay, so that is the classical type of PCOS, type A. Type B is when you have delayed ovulation, so you have an irregular menstrual cycle, high androgens, but no cysts on your ovaries. So we have a clean ultrasound. Type C, you have high androgens, polycystic ovaries, but a normal menstrual cycle. Believe it or not everyone who suffers from PCOS has an irregular menstrual cycle, just as not everyone who suffers from PCOS is infertile. Good. And type D, polycystic ovaries, delayed ovulation, but no signs of high androgen. So these are usually the women who do not have the excess hair growth and the acne and so forth because they do not have high androgens. Okay, so if you suffer from PCOS, from this chart, you will be able to see if you have type A, type B, type C, and type D. But the most common one is type A, where you have all 3. An irregular menstrual cycle, high androgens, and sonography of polycystic ovaries. We're going to move on now to management. Now, most times I do not go very deep into management because the management of PCOS is very individualized. One, because not everybody presents all the signs and symptoms, or there is one hormonal disorder that we may need to stress on in one individual, which we may not need to stress on in someone. So it's very individualized. Okay. Number one, the first thing I want to say to you all is I did a presentation this week and I named it PCOS Beyond the Missed Period. Why? Because most times clients are seen for PCOS. Most times the main concern of the client, and even so the main concern of the physician, is to regulate the menstrual cycle. And I have seen cases where once the menstrual cycle is regulated, then everything else, it's like the problem is resolved and everybody goes on their merry ways, on their merry way. However, the hormonal issues that we've looked at, the insulin resistance, the hyperandrogenism, all of this stays. And then the patients come to me with complications of PCOS because the underlying problem was not resolved. Okay. So the first thing we do in endocrinology is that we identify and we correct the hormonal disorder. It's very easy for you to walk into consultation. You say to me, I have not seen my period in 3 months. It's very easy. That's an easy fix. We can get that fixed in 1 day and you go back home. You never have to come to me again. But did I solve the problem? No. Right? We have to identify what is causing you to have a missed period. And that is what we attack first. Okay, so we identify the hormonal disorder and we had a look at all the hormonal disorders. If you present insulin resistance, then we're going to talk about nutrition, the lifestyle changes that you have to do, which all of us know is very similar to that of diabetes, cutting off the sugars, cutting off the processed foods, trying to eat as natural and as local as possible. We have chemicals, which are known as endocrine disruptors in a lot of the foods that we eat, in a lot of the processed foods that we import, right? In a lot of the meats and so forth that we eat and the dairy products that we consume. So we would have a nutritional plan. You would sit with a nutritionist and come up with a plan to help so that you ingest foods that are healthy for you, okay, to reduce your insulin levels. Physical exercise also plays a very important role because the more we exercise is the more we help our tissues to become sensitive to insulin. A weight loss plan for those who may be overweight, because not all polycystic ovary syndrome patients, not all sisters are overweight or obese. And if and when necessary, medication. So there are clients where we can reverse insulin resistance without using medications, especially if they follow the nutritional guideline, if they exercise, if they lose weight, then we can treat them without medications. There are some clients who fit the criteria to go on medications, okay? And like I said, it's very individualized. Hyperandrogenism, high male hormones. How do we treat it? Weight loss. Now you may say to yourself, what does being overweight have to do with having high male hormones? And it's because the fat cells, one, they have a way of converting our estrogen into testosterone. Okay? And they, through different metabolic processes, can cause a certain level of dysfunction at the level of the pituitary gland, causing an increase of testosterone production at the level of the ovaries. Okay, so weight loss is very important in correcting hyperandrogenism. Insulin resistance can also lead to hyperandrogenism. In some clients, we need to use what we call anti-androgen treatment. So these are medications that we use to bring down your testosterone levels. We have quite a few of them that are at our disposal that we can use to bring down your testosterone levels. Okay, and individual management of symptoms. So, for example, someone comes with acne. We decide how we're going to treat that acne. Sometimes we request the help of the dermatologist, especially when it's particular types of acne that are very difficult to treat, or if the client's skin is sensitive. If someone comes with hirsutism, we go ahead and there are certain creams and so forth that we use to reduce the frequency of the hair growth, and certain medications that you can take to do that also. So it's individualized. Estrogen dominance. One of the main things in estrogen dominance, one, minimizing stress, removing toxins, proper nutrition. If you notice, nutrition is very important, and balancing the reproductive hormones, FSH, LH, and estradiol. FSH and LH are produced by the pituitary gland, and estradiol, estrogen, by the ovaries. Okay. The irregular menstrual cycle, like I said, is one of the first things, one of the main motives for consultation. We have to do all of the above. So exercising, losing weight, balancing our hormones, and in some cases, some clients may need ovulation inductors, which are certain medications that we use to induce ovulation. And infertility, balancing our hormones again, having adequate diet, physical exercise, inducing ovulation, and sometimes some may require assisted fertility methods such as IVF. Okay, so if you notice I did not go into giving you medications, the names of medications and all of that, you all could ask me if you so like in the question when we get to the question section. But these are the general guidelines that we use for treating, and that is what I want you all to take away when you go back to your doctors. It's not just about regulating your menstrual cycle, because you could regulate your menstrual cycle. For example, you could be given a pill, what we refer to as a contraceptive pill. You could be given a contraceptive pill to regulate your menstrual cycle. But did you deal with the insulin resistance? So what I find is clients are coming to me, they're 2 years, 3 years on a contraceptive pill, but when I screen them, they're either pre-diabetic or already suffer from type 2 diabetes. I have a lot of 20-something-year-olds, 30-something-year-olds with very resistant diabetes and hypertension, that some of them have to be placed on insulin. Some of them have to be placed on 2, 3, 4 medication to control the blood pressure level, because we have gotten so accustomed to regulating the menstrual cycle, and we have forgotten that there are other hormonal disorders that form part of PCOS apart from an irregular menstrual cycle. So this is what I want you all to take back to your community and take back to your doctors, that you not only want to regulate your cycle, but you need to find out what is really going on with your body so that you could balance off your hormones to prevent yourself from developing complications of PCOS. Okay, I'm going to place here 2 questions that I get very often, just in case anyone is wondering when it comes to management, so that you all could have a better understanding, because I know that's one of the questions that's going to come up. Number 1, why metformin? So many clients who suffer from PCOS are placed on metformin, and we always relate metformin to diabetes. I'm sure after that presentation, if I ask any one of you why metformin, you're able to answer, because we did see that insulin resistance plays an important role in managing PCOS. Now, not all clients need to be placed on metformin. Okay, we have certain criteria where we use metformin. Metformin has shown great results in clinical trials in helping regulate the menstrual cycle, in reversing insulin resistance, in preventing the client from developing type 2 diabetes, and also with weight loss. Okay, it reduces the formation of sugar in the liver. It reduces the hormone which stimulates the production of sugar, which is glucagon, and it also increases insulin sensitivity. And that is one of the main reasons why we use it. But like I said, not everyone who suffers from PCOS necessarily needs to go on metformin. Okay, it's an individualized case. The next question that I get very often is why contraceptive pills? And if you will notice, I placed contraceptive pills in parentheses. Why? When you look at the box of contraceptive pill, from your point of view, you're looking at a method of contraception. As an endocrinologist, I'm looking at medication, not contraception. So, for example, I placed here for you Diane 35, which is one of them that we use very often. If you can see below Diane 35, it shows you what medications are in there, what hormones are in there. Cyproterone, I'm just going to explain to you so you could understand what I'm saying. Cyproterone is an anti-androgen. Okay, so basically it's in there because one of its functions is to lower testosterone. And then we have ethinyl estradiol, which is basically a form of estrogen. Okay, now when I give you Diane 35, I'm not giving it to you as contraception. I'm giving it to you as a medication, meaning these are the two hormones I need in your system to balance up, to fix your axis, what we refer to as the axis, from your pituitary gland right down to your ovaries. In some cases, this is the one you may need. And that is also very important, not only for the clients to understand, but for the physicians to understand. Because something else that I see very common is that the clients are placed on the wrong type of contraceptive pill to regulate the menstrual cycle. Okay? The pill has to be chosen based on the hormonal disorder that you present. Okay? The pills are indicated not for contraception, but as medication, as they contain the hormones we need to use to balance the reproductive axis. They are not always meant for long-term use, but can be stopped once the axis is balanced. Okay? Contraindication should be respected. So anyone who presents a contraindication, one of the most common contraindications is a tendency to develop blood clots. So if you have someone with a history of thrombosis of blood clots and so forth, then we try to refrain from using contraceptives in this type of client. Okay? So not all types of contraceptives are for everybody because they are medications. They contain, each one contain different types of hormones. So I need to give you the one which has the hormones that I need based on the type of PCOS, based on the hormonal disorder that you have. Okay, we are nearing the end of the presentation. In summary, I need you all to remember that PCOS does not begin in the ovary. Okay, that's another misconception. We think that because we have cysts on our ovaries, that is causing us to have all the hormonal stuff. And it's quite the opposite. Okay? Because of the hormonal disorders that we have, because of the insulin resistance, because of the estrogen dominance and so forth, we develop cysts on our ovaries. Okay, so it's quite the opposite of how we think of it. Its management requires much more than regulating the menstrual cycle, which is what I said. The psychological impact of PCOS should not be ignored. One of the psychological impacts of PCOS, some of them, the most common one is depression. It is also related with other psychological disorders, such as bipolar disorder. The clients have a tendency when they go for depression to have suicidal intentions. And as you all know, especially if you suffer from PCOS, the mood swings. Okay, so we do not have to ignore the psychological impact of PCOS. There are clients who suffer from PCOS who have actually committed suicide. Okay, cardiovascular, high blood pressure, heart attacks, the glucose disorders such as prediabetes and type 2 diabetes, high cholesterol and fat levels, endometrial and breast cancer. We know how common these cancers are, especially for breast cancer. And a lot of times it's because of untreated PCOS. Here you can see an example of all the long-term risks, what we spoke about, the elevated cholesterol and fat levels, low thyroid function, the cancers, the mood disorders, infertility, high blood pressure, obesity, all of this, all of these are held long-term risks of PCOS. Okay, so we cannot take PCOS lightly because it just take some moments, maybe some months, maybe some years for a teenager, let's say an 18-year-old, to have PCOS. Wasn't diagnosed, it wasn't treated, and then we find her having a heart attack in her 30s, and we wonder about why. Because of untreated and uncontrolled PCOS. Those hormones are causing havoc and they were not balanced up. Okay. So I have a little alert that you can take to your brothers and your male friends, because a lot of times when they think of PCOS, they exclude themselves. So they don't come to listen to the presentations. They say, that's for men. Alert, the men are not excluded. Okay? There is what we call male equivalent PCOS, which studies are going on. They haven't concreted the name as yet. And it is defined as a disorder that occurs in men, in male members of a family with a PCOS history. It is characterized by the clinical signs of androgenism, complete hair loss, and the same hormonal patterns seen in PCOS, except that these men present low levels of testosterone, what we refer to as hypogonadism. Okay? So, for example, you may have a family where you have, let's say, 3 children, 2 girls and a boy, and you notice that the 2 girls have PCOS, signs and symptoms of PCOS. Probably one is diagnosed, one is not. And then you have a young man who is overweight. He has patches like thin hair. He has erectile dysfunction, right? The scientific studies are showing, because PCOS has a genetic factor to it, that those genetic disorders are affecting the men also. Now, we cannot call it PCOS, polycystic ovary syndrome, in the men because they don't have ovaries. So I don't know what name they'll settle with, but studies are being done to describe those hormonal disorders in men. So they are not to be excluded. Anytime there's a man in your life, whether it's a brother, a boyfriend, or your spouse who suffers from erectile dysfunction, who is increasing in weight, especially central obesity in the area of the abdomen, who is having, at a very young age, you're seeing that they're having bald patches, low energy, and fatigue. The very same signs of insulin resistance that we saw in the women, that man needs to be evaluated for hormonal disorders. Okay, so I don't want us, because we're speaking about PCOS and the ovary, I do not want us to exclude the men, because genetically they're also predisposed to certain signs and symptoms similar to what happens with the woman. So that's the end of the presentation. It's a very broad topic. It's a lot to speak about. I could tell you all of very interesting cases. One of my first cases of PCOS here in Dominica was a client that was referred because of infertility. Okay. And in a matter of 3 months, she got pregnant, and all we did was correct insulin resistance, because the hormonal disorder that was more predominant in her was insulin resistance. So we got her on the right diet, physical exercise, and she started metformin because she really needed her insulin levels were through the roof. And though she was trying to get pregnant, the pregnancy surprised her. It surprised both of us because we did not expect things to work so quickly. Basically, in the 3rd month of treatment, she got pregnant. Okay, so it's very important not just to focus on regulating your menstrual cycle, but really identifying what is going on a hormonal level and having that fixed. Okay, thank you very much for your attention. If you have any questions, then it would be my pleasure to address them.
Thank you so much, Doctor. That was so informative. I see that there are some comments and questions in the chat, so I will hand over to Liz to ask those questions and read out those comments for you. but then I have questions. I'd raise my hand so that when she's finished with the comment section, I have some questions too. So Liz?
Almost forgot to unmute myself. Okay, wonderful. So we have quite a few comments and questions in chat. Larissa says, I was diagnosed by vaginal ultrasound. No blood test was ever talked about. So sounds like she needs to get some blood work done to find out if it's PCO or PCOS.
Okay, so like I said at the beginning, we have 3 points for criteria for diagnosis. So there's at least 1 blood test that you must do in the diagnosis of PCOS. Okay, 1, remember we said sonography, which has to have the description that I placed for you. So sometimes you could be diagnosed with PCOS based on sonography, based on an ultrasound, and you actually don't have PCOS because it does not meet the criteria that we're looking for. Because remember, you need to have more than 12 follicles or an ovarian volume more than 10. Okay, so you need to at least do a blood testosterone. If we're looking at just diagnosis, for just the diagnosis, we need a testosterone level. Because remember, one of the criteria is high testosterone levels. Unless if, let's say, testosterone is not being done where you are, and the doctor has 2, remember we only need 2 out of 3. So the doctor sees that you have cysts on your ovaries and then you have an irregular menstrual cycle. These 2 are enough for your doctor to diagnose you with PCOS. However, remember, how does the doctor treat you if you don't do your blood test? Because remember, we're not just trying to regulate your cycle or just to see if you have cysts on your ovaries. What we are trying to do is correct that disorder, that underlying disorder. So then I'm going to need to see how your pituitary gland is functioning. So most times I send the clients to do an FSH and an LH. I need to see remember we're looking at other imbalances. I need to see your insulin levels. I need to make sure that you don't have PCOS and low thyroid function or high thyroid function. So I need to see your thyroid function test. I need to see your prolactin levels. Okay, so all of these are tests that you have to do when you suffer from PCOS. But definitely, to concrete diagnosis, at least a testosterone is needed. And taking into consideration that insulin resistance is one of the main causes of PCOS, an insulin test, a fasting insulin test is needed. A fun fact, one of the ways which has been stopped that PCOS was treated before, which just brings the point across that I'm trying to tell you all, that the problem is not with the cysts, because we think that the problem is with the cysts, but the problem is not with the cysts. So one of the ways it was treated before is that the surgeons would go in, what is known as ovarian drilling. The surgeons would go in and it's almost like bursting a bubble. They would go in there bursting balloons and basically destroy the cysts on the ovaries. What they noticed over time, that even getting rid of the cysts did not correct the issues. The patient still continued gaining weight. They still continued with the hirsutism. All the metabolic disorders still continued. Why? Because the issue is not with the cysts. Okay? So if you have not done these tests, then you need to, because that is what's going to identify what exactly is wrong with you on a hormonal level so you could get it fixed.
Thank you so much. I didn't realize doctors had stopped doing the ovarian drilling.
Yeah, it's not first line recommendation right now, unless it's an extreme case, especially when it comes to the volume of the ovary and so forth. Yeah.
Janelle asks, what about blood sugar dropping low about an hour after eating?
Right. So if you notice when I put up the slide of the signs and symptoms of insulin resistance, on there we had high blood sugar levels, but on there we also had hypoglycemia, which is low blood sugar levels. Because what happens is after you eat, you have a high flow of insulin in your bloodstream. And sometimes it can get so high that sometimes the cells intake that insulin and it can cause a blood sugar drop. So not all clients who suffer from PCOS just have hypoglycemia. Most times you will notice that your blood sugar levels are actually normal. because you haven't progressed into prediabetes or diabetes. You're actually still at the stage of insulin resistance. So then you could have excess insulin into your bloodstream, and you have certain times when the receptors are very, very sensitive, and it can cause blood sugar drops. These clients were very, very we have to take a lot of caution with them, especially with the use of metformin when it comes to those cases. So it is possible and very frequent that you have blood sugar drops after eating.
Right. Joanne just has a comment. She says that she has PCOS along with hyperthyroidism.
Good.
Larissa asks, can you list the medication? I also saw Larissa had her hand up. You wanna come off mute and specify which medications you're talking about? Larissa?
Hi, good night, everyone. I just want to overall say something. It doesn't particularly with the medication, but I was just asking for some for clarity at that time. So what is happening, right? I have been diagnosed, well, it's a year, yeah, it will be a year, with PCOS. As I said, I never done a blood work. What I went in with was a book with all of my records of how I felt.
Mhm.
So I used to have, and I used to have strong headaches, back pain, mood swings, and prolonged period, not missed period, not irregular period. So therefore, I might have a period every 36 days, in and out, depend 30 days, come back 28 days, go back 36 days. So that was a problem. So when I went to the doctor now, I did the ultrasound and realized that I have two cysts on my ovaries, one of my ovaries. And what was mentioned is to try and she considered it mild, and to try and work on my diet to increase vegetables was one of the things I was told, and to exercise. So I took that and I worked with it, and I have seen results where now my period comes every 29 days. And then I have seen I don't no longer have headaches, backaches, and all the rest things. A prolonged period, I no longer have these things. But what also have changed also, I have intake something called inositol also, because I'm doing my own research and I have seen or see people's testimony where they say the inositol works, and I decided to try it because I didn't want it to go on the metformin. And I realized that it has improved marvelously, especially with my mood swings and so forth. So there is a change. So I am due actually another visit to the doctor to see where it's what is happening and so forth, because I do see the improvement in myself. So if I do see the improvement in myself, I think well inside it has been improved some way somehow. But generally, that is what I was stemming from when I spoke about not having lab work. I don't know why she never sent me. I have questioned it. She even mentioned about the high estrogen level, the low progesterone, and all these sort of things she has mentioned, but nothing really actually was done to say, hey, this is what you are this is what is the problem. Yes, she did question me about my eat the way how I eat. I'm not a sweet person. I don't go off of sweets. I don't even use sugar. I don't even drink juice. So a lot of questions she asks. I don't really have a high midsection, but um my general body mass has changed since I have incorporated the vegetables and so I get a bit I get smaller, but it walkable. But yeah, that's it.
Okay, so what happened with you is that you corrected, based on what you're telling me, you corrected a hormonal disorder by doing lifestyle changes. And yes, the myoinositol also helped you. It's one of the supplements that I indicate. Okay. Most likely, especially when you're talking about the persistent headaches, most likely you were suffering from insulin resistance. So even though you did not do a fasting insulin test, and that is the parameter you would have had to use. So when you go back to the doctor and then you check your insulin levels, based on how you're feeling, that your weight has been better managed, that you're feeling better, you don't have the headaches, and you would have seen that your insulin levels actually decreased. Because what you're describing to me is the classical syndrome of insulin resistance. Okay. So you would have seen that your insulin levels reduced by changing your diet. Like you said, in your case, you did not need the metformin because you did the lifestyle changes. And to you, it might even seem like you did not put so much effort into it. To some people, it's just mild changes that they need to make, and then you actually corrected a hormonal imbalance without even actually knowing what imbalance that you had. Now, I do not want you all to be too hard on the doctors for not indicating the blood tests. Because even when I got back here in Dominica, some of the labs, they had to send to get the hormonal kits because the doctors were not indicating the hormones. Why? Because there was no endocrinologist on the island. Okay. So it's only now as we're building awareness and I'm doing educational sessions, I'm showing them the importance of really diving a little bit deeper to indicate the hormones so we could see exactly what is going on with each client and therefore to proceed with treatment. So most likely what you were suffering, the hormonal imbalance that you were suffering from was insulin resistance. Okay.
Okay. Odelia asks, are there any medications outside of birth control medications that can be used to balance hormones?
Definitely. So it depends on what hormonal imbalance that you present. So for example, if you suffer from hyperandrogenism, what I don't want you all to do as a side note is equate imbalanced hormones to the irregular menstrual cycle. Remember, when we're talking about unbalanced hormones, we're speaking about a wide variety of things. So for example, in treating hyperandrogenism, especially when the client presents clinical expressions such as the excess hair growth, etc., there are certain medications that are designed that are not contraceptive pills that are designed to drop it. We have, for example, drospirenone, we have cyproterone, we have flutamide. If the person is hypertensive and has PCOS, we like to use spironolactone. So there are a list of medications that we can choose to treat each particular um disorder that you present. There are some sisters who are also diabetic, but they may not be tolerant to metformin, or they might not want to go to on metformin. There are other medications which are anti-diabetics, but they also help with insulin sensitivity that we can use. So it's individualized, but yes, there are other medications apart from birth control. But remember, I said you're thinking of it as birth control pills, but I am looking at it as these are the medications or the pills that have the hormone that I need you to take in that particular moment. And most times, at least in my practice, most times it's not long term. Most of my clients do maybe maximum 3 to 6 months of pills. Those I really need to go on it. Usually in 3 to 6 months, we resolve the issue. And then they can come off it, and then we use other methods and so forth to continue.
Okay. Another question regarding medication. For those persons who have adverse reactions to metformin, what other medication can they use?
Right. So now on the market, first of all, we have two different types of metformin. We have immediate release, and this is the one that we've been using for years and years and years, and is the one which has the most side effects, especially the gastrointestinal effects. So the upset stomach, diarrhea, or maybe even pain. What I try to do first is always to get the patients, at least for a few days, to try prolonged release metformin or extended release metformin. If that does not work, you're not tolerant to the metformin, we take you off the metformin. We use supplements, for example, one of those that were mentioned, or even along with the metformin, we use supplements such as myoinositol, the berberine. There are many other things that we can use to help you to become more insulin sensitive. Or if we cannot use the metformin, then we have to up the diet. Okay, so I put you on a very strict dietary plan. We up the diet and the physical exercise so that naturally, that's why I told you all, not everyone needs metformin. So that naturally your body can become more insulin sensitive. Some people just with proper diet, with exercising and a proper weight loss plan, they revert the insulin resistance without the use of metformin.
Oh, thank you. Janelle Janelle asks, what about if you missed menstrual cycles and then after that you got frequent cycles and prolonged bleeding? Does that,
Right.
yeah.
So that is called, at first when you miss the cycle, it's called oligomenorrhea, and then very, very common presentation. And then after you have the period which lasts very long or excessive bleeding, it's called polymenorrhea. Okay. And that is also a sign of, like I said, your hormones not being balanced. Right. So I would need to check what exactly is going on, and then that would tell me what I need to do to get that fixed. Yes, the issue might be, it stems back to everything that we're speaking about, the high testosterone levels. So, for example, especially with polymenorrhea, the high testosterone levels, that tends to happen a lot. The excessive bleeding, the bleeding for long periods, or sometimes it's not a heavy bleed, but spotting. And that's one of the main common things on the hyperandrogenism. So the first thing I need to do is to bring down your testosterone levels. And that is why it's important to do the test. Because like I said, it's very easy for me to put you on birth control, on a contraceptive pill that's going to stop the polymenorrhea, that's going to stop the excessive bleeding. But have I treated the underlying cause? So that is why it's important that we get the hormones done so that we could know what exactly we need to treat, not just to cover up what is going on, but to fix the underlying problem.
Wonderful, thank you. Next question is we answered this one already about tolerating metformin. Next, do you do virtual consultations? I'm from St. Lucia and would really like to speak with you.
I do. I would have to speak with you individually so you all could look me up on Facebook, Natasha Maxime. You will see my name there. You could just send me a message for Messenger and we'll take it from there. Depending on where you're from, we have some things to talk about, but yeah. And I'm always there willing to help anyone who needs my help.
Can you put your handle in the chat? Thank you. Next question, is it possible for someone to have regular testosterone levels and still experience hirsutism?
Hirsutism, yes.
Hirsutism, yeah.
Not all, like I said, not all excess hair growth is hirsutism. And not all hirsutism is caused by excess hair growth. One of the main causes of hirsutism, genetic. So you could have some genetic predisposition which causes an overstimulation of your hair follicles, okay? And usually it's familial. So you would have another sister or your mom and so forth in the family who are very hirsute, who have excess hair growth, right? You could have adrenal causes, so not necessarily at the level of the ovary, but you have a little extra production of some of the male hormones at the level of your adrenal gland, which can cause you to have excess hair growth. So not all hirsutism is because you have PCOS, or not everyone who has PCOS has hirsutism. There are other causes of hirsutism. And a lot of times it's genetic. So when you have a genetic predisposition to hirsutism and then you still suffer from PCOS, especially with hyperandrogenism, then it becomes really difficult even to treat, even to manage.
The next question says, can you reverse fatty liver?
Yes. One of the main ways to reverse fatty liver is very simple, getting rid of the fat. So one of the main things that we have to work on is one of the main things that we have to work on is weight loss. Okay, so we could decrease the fat deposits.
Okay. Okay, two more questions. The next one says, what would cause the cycle to regulate for a few months while taking supplements and stop for a few months and eventually start back months later?
Taking supplements or taking medications or the birth control? because there is a difference with taking supplements, for example, myo-inositol, berberine, and taking a contraceptive pill. However, the answer remains the same. Most times it's because the underlying cause has not been treated as yet. Okay, because the supplements will help, yes. The contraceptive pills will help, yes. But the underlying cause has not been treated as yet. And that's why sometimes a lot of women, after they come off from the pills or they stop taking the supplements, they revert back to the same signs and symptoms, to the irregular menstrual cycle and everything they were feeling before. It's because the underlying cause has not been treated as yet.
Okay, and the last question is, when your hormones are balanced using contraceptive pills and you stop taking it, would your hormones become imbalanced again and you have to return to taking the medication?
It depends. It depends on what hormonal imbalance that we use. So, for example, and if you all notice, I keep referring to individual hormonal imbalance and not just in the broad term. So, for example, if I have a client who suffers from hyperandrogenism, right? Irregular menstrual cycle. 1 month she gets her period, the other month she doesn't. The time she bleeds for a very long time, but I'm seeing that her male hormones are very high. The first thing I do is not put the client on birth control. That's not my first step, right? Which is where we fight a lot. The gynecologists and the endocrinologists, we fight a lot because of that. Because usually their first step is to give you birth control. But my first priority is to bring down your testosterone levels. Okay? And the first way I bring down your testosterone levels is not by giving you the birth control, but by using anti-androgens, which are medications designed to drop your testosterone levels, right? So it all boils back down to getting the hormonal disorder under control, identifying what it is and getting it under control. Or else you're going to be placed on a contraceptive pill for probably a long period of time. The original problem was not fixed. So then as soon as you come off from it, you go back to having an irregular menstrual cycle, you go back to having all the signs and symptoms that you had before. Or another thing which happens is that some people put on weight. So you're placed on the contraceptive pill, but then one of the side effects of the contraceptive pills, they tend to increase your appetite. And that's not a problem because your appetite can be increased. But then if you eat healthily, then you can combat that effect. But if you eat unhealthily, you eat a lot of sugary stuff and starchy foods, etc., you put on weight. That weight, now remember we spoke about the role of fatty tissue and how insulin resistant they are and so forth. So it's like a vicious cycle. So then you stop the pill, but then you gained weight during the period of time. So then basically, instead of progressing in the right direction, you regressed. Okay?
Understood. We're getting close to time. So these two questions, we're gonna end it with those. The next question wants to know about supplements. Which supplement should be taken, myo-inositol or myo and D-chiroinositol? Like which one is better?
The one with mayo, once it has mayo in it, not just the plain inositol is fine, but the mayo inositol is better. Okay, the mayo and D-chiroid could also be used. So any one of these would be fine. Once it has the mayo inositol, that means it has another ingredient, another compound in it, which it helps than the basic inositol. So when you're purchasing it, try to get the mayo inositol. Okay. We also have when you all contact me, I could send you, because I have them on my phone or on my PC, some other supplements that you could use. And we also have here in Dominica, we have a company called Herbal Harmony. This is a young lady who suffered terribly with PCOS, and she did research and so forth, and she came up with tea bags. And in there are natural leaves and so forth that we use to help manage PCOS. She has one specifically for PCOS, and there is one which I use, which helps with the premenstrual symptoms. So with the colic and all those abdominal pains and nausea and all of that, they work very well. Okay, the company's name is Herbal Harmony. I'm not sure if she ships to St. Vincent, if you will have it in St. Vincent, but the teas, they help very, very well. There's actually one designed for PCOS.
Very nice. Last question in the chat and then raised hand. Can ovarian cysts be removed surgically?
Yes, so ovarian cysts can be removed, especially depending on the size. We may opt to having a few of them removed. However, what I want you all to understand is that removing the cyst does not solve the hormonal issues, because it was the hormonal issue which caused the cyst and not the other way around. It wasn't the cyst which caused the hormonal issue. So though because of ovarian size or some of the structural complications that you may produce, we may opt to have some of the cysts removed, but it does not treat the hormonal disorder. Okay, so it's more like a structural issue than a metabolic or hormonal issue.
Very nice. Odelia?
Hi, good night,
Good
everybody.
night.
Doctor, I was listening to the presentation. You've answered some of the questions that I had, but I am coming from a different perspective. I'm coming from the perspective of somebody who has PCOS. Well, currently I have PCOS and endometriosis. I've had a hysterectomy because of my adenomyosis and fibroids. And, you know, before I thought that, okay, I've lost my ovaries, so I don't have to deal with the PCOS anymore. But I was kindly informed by my doctor that that is not so. There's no such thing. So I'm still struggling with the managing both conditions. So at the time I had the hysterectomy, I also did an excision of the endometriosis, and I have bowel endometriosis. So my doctor had tried metformin, and that made me really sick because I already had bowel issues. And then the metformin with the side effects, just, it was horrible. So I didn't even last 5 days on it. So I've been trying to find natural ways of managing endo-PCOS, sorry, and menopause. Dealing with all of the symptoms that come with all of these conditions and the contraindications of each and the medications. And I also have insulin resistance. So,
Good. So you are a perfect example of what I've been saying.
yes.
That the issue is not, the base of the issue is not
Not the
the
ovary.
cyst on the ovary, because you could have the ovaries removed, or you could do ovarian drilling, and then you're still left with the hormonal disorders, which are what caused the cyst on the ovaries. Okay? First, you would have to prove to me that you do not have your ovaries, because a lot of times clients are confused when the doctors say that you did a total hysterectomy. You're thinking that you don't have your ovaries, and then we do ultrasounds and your ovaries are perfectly intact. So you
Yeah,
have to
definitely don't have
prove to
them.
me that you had oophorectomy, not only hysterectomy, but oophorectomy, which is the
Yes,
removal
I
of your
did that.
ovary.
Yeah.
Then we have to study you to see what exactly is going on. Is it just insulin resistance? Is it that you have insulin resistance, but you have hyperandrogenism? What is exactly going on? Now, with insulin resistance, if you can make major lifestyle changes, you're placed on a diet, if you're overweight, weight loss, and so on, then we can actually correct the insulin resistance without having to use metformin. We can engage some supplements and so forth in there to get you to bring your insulin levels down. So we go back to what I've been saying from the beginning of the presentation. The first step when treating PCOS is identifying what is wrong. So apart from the endometriosis, if we were to look at the PCOS, we have to identify what is wrong with you hormonally. And then from there, we can decide what treatment that we use.
Thank you. I'll send you a message.
Okay, you're welcome. No
All
problem.
right.
So we're done with all of our questions. There's a couple comments. Thank you for a wonderful presentation on Facebook. Very informative, Dr. Esprit. Very informative session. Thanks, Doc. And yes, I would also want to add my thanks to those comments. Thank you very much for a wonderful presentation and answering all of our questions.
You're welcome.
Yes. Again, I want to thank you, Doctor, for responding favorably to my invitation to have this session. It was very, very informative. I learned things that I didn't know before, especially the male PCOS. It will make for a really good conversation with our men.
Yes.
Just like when I do presentations on endometriosis and I tell them that, you know, men can all, it's rare, but men can also have endometriosis, and everybody is shocked. I don't know why I was shocked about the PCOS one, but we learned something new tonight. And I really appreciated you taking the time out and going deeper into PCOS and the hormonal imbalances that are just more than your estrogen and your testosterone, and you really went into other things that we need to be looking at. So I really appreciated you taking this time out on a Friday night when you could be outlining. So I wanted to say thank you very much from the
You're
association's
welcome.
end, and from all of our wonderful guests who have joined us both here on Zoom and on Facebook. I am sure everybody is really appreciative of the information that you have shared with us tonight, and I'm sure you'll be getting some messages on Facebook and on WhatsApp. So we really appreciate it, and we look forward to having another session with you again.
Thank you very much for the invitation.
All right. And with that, we say good night, everyone. Thank you for joining us. The Facebook Live will be left up on the page. So if at any time you want to rewatch it or you want to look back at anything that Dr. would have shared with us tonight, you will be free to do so. So it is on our Facebook page, the SVG Association of Endometriosis, Adenomyosis, and PCOS. And with that, we say thank you and good night.
Good night.
Good night.